Welcome to our first class for the spring semester for economic evaluations in healthcare. This is Errol Pierre. Thanks for joining. And we'll be going through the first two chapters, 3 slides for the 2019 spring semester. So let's start out with discussing what exactly is health economics. Health economics is the study of the allocation of resources to and within the health economy. And what that basically means is it discusses and studies how someone spends a limited amount of resources. All throughout our class, we'll talk about how we have too much demand, and that's Americans seeking healthcare, and too few supply, and that's the doctors and the hospitals and the facilities that can offer healthcare. And so economics is a study of how we make decisions when we don't have enough supply for the amount of demand we have. And there's tools that are within the health economic world that help us make the best decisions, and we'll go through some of those tools. So the intent for this course is that you're able to apply some of these economic principles to healthcare to answer questions on scarcity. Scarcity basically becomes the theme through many of the chapters that we will visit throughout this course. So our goal will be, let's outline the current issues that exist in healthcare, and then based on those issues, let's understand how to apply some economic principles to those issues. So let's talk about the issues in healthcare. The first one is cost. As of this year, 2019, healthcare is 1/6 of the economy, 17% of GDP. That's massive. And why that's an issue is we have an aging population that's consuming more healthcare dollars. And so it's diverting more tax revenue to Medicare and to Medicaid and to healthcare. And why that's an issue is, as you know, we want to spend our tax dollars on education, on infrastructure spending, on technology, on research. However, healthcare is growing so much faster than any other industry that it's taking disproportionate share of money from our tax revenues. And the fear is healthcare grows too fast, it'll consume too much of our tax revenue and basically stall the economy. And then we can talk about the issues in healthcare in relativity to other countries. So there's lots of data out there and research that shows that we are almost 2 times more expensive than any other developed country in the world. So if you look at Germany, Britain, Canada, Norway, Italy, Japan, all of these developed nations, the United States is spending more money, and this is per person. So this is a per capita spending, and also as a percent of GDP, we're of the highest. Most developed nations average around 10% of GDP, 9% of GDP, 11% of GDP. And again, we discussed a little bit earlier, the United States is upwards of 17% of the gross domestic product, which is very high. Access. So we still do not cover all Americans. This stat is a little old. It's no longer 37 million people that lack insurance. It's closer to 20 million, but still close to 8% of the United States are uninsured, which means they don't have coverage. So when they do have to get hospitalized or do have to get health care, they're going in the most expensive manner possible, which is the emergency room. By law, emergency rooms can't turn people away for urgent and emergent care. So rather than someone seeing a primary care physician, where costs are much lower, if they don't have any insurance, they're going straight to the emergency room, which means they're also waiting till they're that sick to go to get care versus going in a preventive manner, trying to go early when they're not sick to find out sickness that could be coming down the line. They're going later after the fact when costs are more expensive. Inflation. Healthcare costs continue to rise, and they rise faster than many other industries, and we have a slide to show you that. Healthcare is interesting. In most industries, once you add technology, cost decreases. Think about TVs, flat screen TVs, 10 years ago, very expensive. Now, very cheap. Think about the technology that Uber is bringing to taxis outside of the surge pricing. The technology that Uber brought and Lyft brought and the other apps out there made it easier and made it the transactions much easier and simplified to get taxi cabs. And then I know in some cities, maybe not New York, the prices for cabs dramatically dropped as well because there was an influx of supply, and when supply grows, price goes down, which we'll talk about. Quality. So despite us paying all this money for healthcare, 70% of GDP, we're not getting the quality that we pay for. And this means that if you look at the world's metrics around what's considered a quality healthcare system, they look at high baby birth morbidity. They look at, do people get mammograms on time? They look at, do folks who have diabetes, are they getting their blood tests on a timely manner? They look at how often are people taking their medication when they have chronic diseases. There's a whole host of quality metrics that we look at. And America lacks in many of these regards. They're usually at the bottom of the list. I'll upload some information particularly on this to show that despite the amount of money we're spending, the money that we're spending doesn't translate into having the higher quality scores, which is bad for our citizens because that means they're not getting the healthcare that they deserve. We talked about the aging population. The baby boomers are turning 65. They're consuming more healthcare. We currently are not ready for the level of baby boomers that will retire in terms of having enough supply and physicians to take care of it, and also the cost impact of having way more people that are consuming much more healthcare. So in terms of the cost, or are we ready for the amount of dollars that will go up because this older population is consuming more healthcare? Plus, we will look at a case study in this semester that discusses why healthcare costs went up. And it's not always because people are getting sicker and they have a higher disease burden. It's also because the treatment for each cost, for each procedure is getting more expensive. So you have people, the disease burden increasing, and you also have the price per treatment increasing as well. So it's an exponential growth that's happening in healthcare. Heterogeneity. So this is interesting because when we look at other developed nations, many of them, are very homogeneous, meaning all of the people look alike, they're from the same culture, they have the same internal structure. And so, when you look at like a Norway or Sweden or even a Germany, which has some diversity, for the large part, the doctors are trained on Germans or on Norwegians, and the patients that they'll see look very similar to the patients they were trained on. And so when they think about treatments, the treatments for the vast majority of the population work because the vast majority of the population is very similar. United States is rare in that we do have high levels of diversity in our country, and the diversity is in pockets. And so an example I always like to share is if someone goes to med school in Kansas, right, and they're learning about that patient population in a residency program, but then they get their residency and they get their job full-time in the Bronx, they're seeing a total different population, which has different healthcare disparities. And so understanding the nuances by culture, because there's some diseases that African Americans are more susceptible to, or Asian women are more susceptible to, or Hispanic populations are more susceptible to. But if you haven't trained with those different cultures, sometimes you don't learn of those cultural impacts to healthcare, and you don't learn about the healthcare disparities. So one of the things that we're challenged with in America is making sure we have the right providers, the doctors, the physicians, and that they're trained for the populations that they'll end up serving. And that's more so of a burden in the United States than what we see in some other countries. And then lastly, competition. Competition is a large barrier to access the market. And what that means is it's not easy for a health insurance company just to pop up and start making money. In actuality, you've seen consolidation where health insurance companies are consolidating, even with pharmaceutical companies. Just most recently, you saw Anthem, one of the largest health insurance companies, my employer, tried to merge with Cigna, another large health insurance company, the fourth largest health insurance company. If they came together, that would have been a consolidation, which means prices would have gone up because together they could demand a higher price. You've also seen Aetna merge with CVS. So again, more price consolidation. And ESI, which is a pharmacy benefit manager, is merging with Cigna, and Cigna's now purchasing them. And when they combine themselves together, they're able to negotiate higher rates because they have more leverage. So rather than having lots of competition, which lowers price, there's actually a lack of competition because you see this consolidation. And we'll also talk about competition on the supplier side too. It's not easy for someone just to become a doctor. They have to go through years and years of training. It's very competitive. And so because there's also high competition on the supply side, it's not easy just to enter the market. There's an ability to keep costs high, because if there's low supply, the suppliers can demand a higher price, right? And that's basically when you say it's a seller's market, the seller can command a price. And the same thing happens in healthcare. There's less doctors, and it's hard to be a doctor, so doctors can charge more for their services because the consumer demand is high. So this was a very quick run through of the issues with healthcare. There's lots more data on each one. I mean, there's papers written on each one in more specificity, but we just wanted to go through why our healthcare system is so inefficient. Many people always ask, why are we so expensive? You could rattle through any of these to discuss why we're so more expensive with less quality than our other peers, other like countries, developed nations. So let's talk about who are health economists. 96% of health economists hold doctorate degrees, nearly three-fourths in economics. Most work in university settings. You can see some work in nonprofit and government organizations. And only 24% hold appointments in economic departments. And this is just to show you that if you want to pursue this long-term, potentially the jobs that are out there, we at Anthem and the subsidiary Empire Blue Cross Blue Shield, we do have a health economics department. And some of the things we're looking at is what are the reasons that there's increases in cost. So we do very big deep dives into utilization trends and cost trends. And so an example would be if there's a surgery, say bariatric surgery, we would look at that surgery over time. From 2016 to 2019 and try to see what caused the increase for that surgery. Was it more people are getting it? Meaning doctors are now saying, I'm going to offer this up to patients more often. So we had more patients in 2019 had that surgery versus in 2016 on a per capita basis. Or is the surgery costs increasing? And so it's the same amount of people every year, but it's a more expensive surgery. And then we would look into, well, what is driving that cost? And so that's the level of economics on the health economics that we do on the carrier side, and that would help us develop medical policy. So maybe we would look at those surgeries and say, were all of them needed and required? And that's when you get into medical necessity. And that's when you get into authorizations and some of the things that we do on the insurance side to try to keep costs low. That all derives out of health economics, just to tie the two together. So why is it relevant? So we talked about health economics is focused on the scarcity of dollars, right? And trying to figure out how to spend money when you don't have enough to go around for everybody. So this shows you the percent of GDP that healthcare was from 1960 to 2020 estimated. 1960, roughly 5%, a little bit over 5% of GDP, and it has skyrocketed to a projected 20% of GDP, one out of every $5 going towards healthcare. Again, this is going to consume our country's resources and stop us from spending money on other things that the country needs, like education and like infrastructure. So this is a big deal that's growing so fast. You'll see from 2005 to 2015, you'll see actually 2010 to 2015, you'll see it be flat. That's an amazing place to get to, some flat costs. But again, those were projected. The reason being that was done was largely due to the Affordable Care Act. When President Obama passed the Affordable Care Act, the intention of it was to keep costs flat. And the theory behind it was we were going to take the uninsured populations and give them health care. By giving them health care and health insurance, they would see the doctor early on and not later on through the emergency room. By doing that, costs would go lower because we would detect things earlier in the process versus later. So we could prevent higher costs, sicklier outcomes. So that's why you see it flat. It did go up slightly, and it's projected to continue to go up. But the job of a health economist is to try to make sure not that these costs go flat, but what can we do within our industry for the cost to go down? So when we talk about your paper, some of the things that we'll be looking to do is what are the ideas to try to make healthcare costs come down? And as we go through each chapter, you'll learn some of the things that make costs go up. And the intent is, let's think of policies to reverse it. Just looks at the people who are employed. This is back in 2009, the most relevant data I could find from the Department of Health and Human Services. But it just shows you the amount of people that are employed, 139 million versus the amount of people in health services, 15.5 million roughly. And the key to this is there's a proposal out there, which you're actually writing a paper on, called Medicare for All. And if there is Medicare for All that launches, some of the impacts we do have to think about is jobs in health insurance and also jobs in some of these other healthcare clinics and hospitals, because in theory, Medicare for All would mean reimbursement to physicians and hospitals and clinics would be reduced to Medicare for all products, including commercial insurance and private insurance. And if that reduction does happen, it would impact the salary that those hospitals could spend on their staff. And so part of the Medicare for All bill has to conceive of potentially retraining programs so that people who are in these roles, if that ever gets passed, can find new homes. It's very similar to what we would do with the Green Deal, saying, hey, what do we do with coal miners? Coal miners won't be working anymore, so we have to find them new jobs to do when we start to do green jobs, for example. So something very similar has to happen as well with Medicare for All, just thinking about the amount of people that are in the healthcare space working as employees. So this is an interesting slide. It shows from 1970 to 2009, the amount of people that were working in the healthcare field, and you see them by physician versus registered nurses and pharmacists against the US population. The thing I want to focus on is 2000 to 2009. If you look at the physicians, they grew from 813,000 to 972,000. That's a growth rate of roughly 19%. If you look at the registered nurses, 2.1 million up to 2.5 million, that's a growth rate of roughly 18%. But then look at the US population, which is in millions. 281 million people in the United States in 2000, grew to 306 million by 2009, growth of 9%, yet doctors and nurses increased by 19 and 18% respectively. Why do you think that is? That's going to be one of the questions we put on the discussion board to get your thoughts from the class. Okay, national health expenditures. So we talked about this. From 1960, the amount of money that the country was spending on healthcare as a percent of GDP was 5.2, and you skyrocket up to 2009, it's 17.6. We looked at the chart that said by 2020, it's going to be 20%. But then this is the key here. The last three columns are called CPI, price indexes. What is CPI? Consumer Price Index is taking the goods in one year and showing them in another year and showing the increase of those goods year to year. So For 1960 to 1970, healthcare costs, you can see, increased to 38% from 1960 to 1970. The CPI is 38, right? But then look at the bottom line when you get to 2009. Look how much CPI is growing. And this is all consumer goods. This is not just healthcare. So it takes, the reason why we do this is we say we want to see how much goods are going up in general year over year. And then we can compare that to other industries to see if there's differences. So the CPI in 2009 was 214.5, yet hospital and healthcare related services was 567. And if you just look at physician services, it was 320. So there specifically, hospital costs are skyrocketing from 2008 to 2009. Physician costs, not as much, but are still growing faster than regular CPI from 2008 to 2009. This is what we say when we say healthcare is growing exponentially too fast. And this is why we think it's going to be 20% of GDP by 2020. We have to slow this down. And so some of the things we'll talk about is why is hospital costs price indexes 567.9 in 2009. That's extremely high. We have to figure out a lower price point year over year for hospital costs. Now, part of it could be, and the argument, devil's advocate, could be, hey, we have an older population and we're able to keep these people alive longer. Back in the 70s, life expectancy was only 60 years old. So we didn't have the cost of someone from 60 to 80 years old in that CPI. But today, we have people living from 60 to 70 to 80 to 90 years old. And we're keeping them alive with medication, with drugs, with surgeries. And so people are living longer. Another example is hip replacements, right? If you're giving someone a hip replacement, they can walk and be more mobile. They can work longer. So they're a more productive person of society. So that's one of the reasons why we say healthcare costs are going up. However, that's not going to explain all of the increases, because the same would be happening in other industries. There's still something else happening in our healthcare industry that's causing this to go up. And it's alarming. The 567 is alarming. And this is the reason why health economists exist, because we're trying to lower this cost. So what is an economy? So if you take a step back and say, let's just look at what's an economy. You need a buyer and a seller. The minute you walk out of the train and it starts to rain and someone sells an umbrella for $5 and you want to buy that umbrella and you buy it, that's an economy. You had a buyer and a seller, and the buyer wanted to get something and have a good, and they're willing to exchange cash for that good. A seller had a good to sell, and they're willing to accept the cash for that good. And that transaction created the economy. The buyer and seller must have supply and demand. So you need the demand for the umbrella, and someone needs to supply the demand. Transfer of money for the good or the service. Then there should be competition. Now, usually there's more than one umbrella guy who's hanging around the train stations. And so the reason why it stays at $5, because if one guy says no, you can walk a little bit further and find another guy who's selling the same umbrella for $5. So it keeps costs low. Plus, they know if they charge $10, you might say, well, let me just run to my car and I'll make it and get a little bit wet because I'll buy an umbrella another day. So that competition that you can buy an umbrella someplace else is one of the reasons that keep costs low. When you lack competition, it's a monopoly. There's no one else competing against you. When you have a monopoly, the person who's doing business is the only person who can sell the good. They can make the price whatever they want, no matter what. The key here, too, is the next bullet, the intent to maximize value and profits. So the only reason why people get into business is to make money. And the trouble with healthcare is people say, well, that's not why I got into the business. I got into the business to save people and take care of people. However, whether you're a nonprofit or a for-profit, the reason why we're in an economy is to maximize profits. And so hospitals and physician groups and health insurers and pharmaceutical companies, whether we like it or not, when they're in this economy, they're looking at the competition and they're trying to maximize profits. And then the last thing that makes the economy work is equitable access to the same information. This is key. We're going to talk about why this doesn't exist in healthcare, but for an economy to work, the buyer needs to know as much as the seller. When that type of knowledge transfer occurs, There's no way for prices to be higher than there should be. And so think of a mechanic. If I know cars really well, when the mechanic tries to say that, the funniest sound in my car is going to cost $5,000, I'm able to say, no, that's not true. It's only $300 because of X, Y, Z. And so that when there's that level of information on the consumer side and the supplier side, costs stay low. As you know, in healthcare, it's not the case. It's a one-way street. Doctors know way more than we do, and so we have to sort of listen to what they say, which can cause costs to go up. So we had kind of just alluded to that. How is buying a car under these factors different from going to the hospital for hip replacement? So think about it this way. There's so many websites where you can check the MSRP of a car, and you can shop online to see which dealer is going to sell which car by what price. And you can actually think about the true discount because you know how much the car is selling for. And you could do your research, and you can look at quality, and you can look at the Carfax and see if the car was used before, if it had any accidents. Hip replacement, very difficult to get pricing to say how much is the hip replacement at Mount Sinai versus Northwell, and then also who's the physician that's doing it, what's their quality levels, how many surgeries have they done before, all that type of data for the buyer of healthcare, the patient, right, becomes the buyer of healthcare, the consumer. For the consumer to have as much knowledge as the physician is impossible. And so in that issue, that's inefficiency. We call it inefficiency in the economy, which causes price to go high. Whenever there's inefficiency in an economy, price goes up, and it's negative to price. It impacts the ability for prices to come down. So our intent is to maximize efficiency throughout the economy. So when we think about the economy and bring that to healthcare, let's think about how to analyze the health economy. So when we talk about scarcity of societal resources, we talked about this. We don't have enough doctors to take care of all of our patients. So there's a scarcity. So when we think about how to make decisions, we have to think about the opportunity cost. This is a key vocabulary word in health economics. And what opportunity cost is, it measures the decision of what you give up. The value of what you give up is the decision. And so what does that mean? That means if I choose to take care of one patient, I have to look at the cost and the impact to society of not taking care of that other patient. Because I have two patients in my waiting room. I can only see one patient at 9 o'clock. I choose to see one, right? Now, say the person who came in at 9 first just needs a preventive visit, and the person who came in second for the 9 o'clock visit is very, very sick. The opportunity cost of seeing the preventive person first, it potentially could be the very, very sick person gets sicker. And so you would weigh the cost to society of not seeing that person against the decision. And so health economics makes decisions based on the value of what you give up. And the intent of that is you never want to have the value of what you give up be higher than the value of what you choose. And so from a health economist perspective, they will always make sure what they give up is less value than the decision they make. And so that changes, think about when we talk about the emergency room, or when we talk about giving out drugs, or when we talk about surgeries. Think about a health economist approach to healthcare from that regard versus the way we do it today. It's not equitable. The intent is not equitable. The intent is to say, let me look at all my options, which would be the one that is the greatest value of me not doing. And that's the one I'm going to do. That's how you make your decisions. You don't make it based on who's first. You don't make it based on who has the most money. You don't make it based on customer satisfaction. So you totally make it based on what would be the worst mistake, basically. What decision would you give up that has the most value? In the health economy, there's a huge assumption for consumers that we make rational decisions, that we do what's best to make sense for me. And so that means you're making decisions on the margin. You're going to hear this word margin later on in the semester. But that means you would not make irrational decisions. Ironically, in healthcare, we do make irrational decisions because there's emotions involved and because there's loved ones involved. So sometimes we say we want to pursue certain healthcare paths or treatments that potentially have very low success rates, right? And that potentially hurt or painful to the patient. And we would do that because we love them. We want to make sure that they stay alive. We want to make sure that they have a chance. And if you're just looking at the data and looking at it very much statistically, that would be considered an irrational decision. So in a normal economy, people are making rational decisions. They would only make decisions that make sense. They would say, if there's a low degree of success for this treatment and it's very, very expensive, I won't do it. But in the health economy, that's not the case. And that's one of the reasons why our costs are so high, because we do experimental procedures and we do pursue treatments that potentially have low success rates because of the emotional piece that comes in, that gets involved in the health economy. And that gets to the concept of marginal analysis, the impact of incremental costs on a decision. So the way we look at it is we say, if I had $1 more, how would it change my decision? Or from a supplier, if I supply healthcare, with $1 less, how would I change my decision? And so it's the incremental cost on a decision. And we'll talk about specific examples of that. But you look at it as saying, I'll keep doing this until a certain point. And at that certain point, that peak, I'll stop doing it. And so the marginal analysis tries to understand and back into what that point is. And lastly, a lot of our examples throughout the course are going to be economic models, and they're always going to look at what happens in a controlled environment. So when we do graphs and charts, you'll see it, and it'll assume a perfect world. And so the intent of health economics is, let's look what it would look like in a perfect world, and then from there we can derive what it potentially could be in the real world. But it's just a good thing to know. So why does economics apply to health and healthcare? That's the big question. In some aspects it does, in other aspects it doesn't. But like we said, there is not enough doctors to take care of all of our citizens in America. Also, consumers don't choose to be sick. So there's always healthcare demand on the consumer side, even though there's scarcity on the healthcare supply side. We do have to make decisions based on money. So we try to make rational decisions and say, is this surgery too expensive? Is this drug too expensive? However, we purchase insurance to offset that cost, right? So that changes our decision making, because a surgery that could be $500,000 only ends up being a copay or maybe $1,000 deductible because of insurance. So that changes our decisions on the margin. That incremental cost becomes different. And then everyone's different. So when we look at a typical model, right, we might say this is what a typical person would do in a controlled environment. But then when you're with a family and you have to think about what they've been through and their past and potentially how much money they have in their health insurance policy, they may make different choices. And so we're going to look at sort of the macro level of health economics, but just understand that people can make very individual decisions at the micro level. So here are the issues with health economics. Presence and extent of uncertainty. And this is what I talked about in the last slide. Consumers of healthcare never know when they're going to get sick. So think about anything else that you are buying. You know when you want to buy it. You want to buy a house, you can decide when to buy a house. You get hungry, you buy food, right? Healthcare is something where you really can't budget for it because you don't know when you're going to need it or use it, and you don't know how much it's going to cost. That presence of uncertainty makes the demand for healthcare higher. So just out the gate, we already have a high demand issue in healthcare. And when you have high demand, costs go up, right? So if we were going to try to lower costs, we would try to figure out how to lower uncertainty. And we would try to figure out how to make People know when they're going to get sick and make it more predictable, because if something's more predictable, then people can plan for it. There's less angst, and then demand goes down. Prominence of insurance. So we're going to talk about in some of the chapters that insurance transfers risk from one entity to another. And what that means is, we talked about it, that $500,000 surgery, you no longer have to pay that out of pocket, because you end up paying $500 a month for a health insurance policy. By buying health insurance, you transfer the risk from yourself to the insurer. So the insurer is on the hook for the big surgery, and you're just on the hook for the monthly premium. When you transfer that risk and it's no longer you spending that money, your decision-making changes. When you know you don't have to spend $500,000 and you know that you only have to spend $500 a month, now it's more predictable, right? So that insurance brought predictability into healthcare decision-making. Now it's more predictable, demand goes down, now you have that surgery, you might want the best surgeon, you might go to the best hospital. Why? Because that payment isn't coming from you, it's coming from the insurer. And so your decisions make, and that goes back to marginal analysis. Now you're making different decisions on the margin based on how much money you have to pay out. Asymmetric information. So we talked about this. In the healthcare economy, the doctor knows way more than the patient. So the doctor can say, this is what you need to do. This is the procedure you need to take. This is the medicine you need to take. Outside of Googling it or going to WebMD, the healthcare consumer doesn't know better, right? So they may get a second opinion, but still, because there's so much asymmetric information, this one-way street where the doctor's telling me what to do and I'm sort of trusting them that they're right, costs end up being higher, because it's not like buying a car where I can go online and find out the actual cost of the car and then go to individual car places and see which one has the cheapest one. I can't do that in the healthcare market. And since that happens, healthcare costs go up. We have nonprofit firms. So in New York State, hospitals are not allowed to be for-profit. However, urgent cares like CityMD are allowed to be for-profit, and health insurers like Empire, Blue Cross Blue Shield are allowed to be for-profit. So this mix and mingle of nonprofit firms versus for-profit firms does bring a level of complexity to the market. Now, despite the fact that hospitals are nonprofit, it doesn't mean that they don't make profit. Some of our largest hospitals like Northwell do make a profit, even though they're nonprofit. All it means is that they are not being taxed on the revenue that they earn. We talked about restrictions to competition. It's very hard to enter the healthcare market, whether you're a provider or a hospital or the urgent care. It's very hard to enter the supply side. So when supply is low, costs go up. But it's very easy to enter the demand side, because that's just getting sick. So when it's easy to enter the demand side, hard to enter the supply side, cost goes up. And that gets to equity and need. And then we have government subsidies and public provisions. So government subsidies, an example, is Medicaid and Medicare. Low-income folks get free healthcare. They get Medicaid if they make below $16,000 a year, roughly $8 to $9 an hour. Because they're getting it for free, the thought would be they use it more, but that's not actually what we see in the data. And so we have to think as to why. But government subsidies also occur in the provider side. There's lots of money that comes from the federal government and the state government to pay for hospitals that are under the water, that are not making money. And what does that do? It props up entities that necessarily wouldn't exist if not for the government. So the government does manipulate and change the economy of healthcare in New York and in other states too. And that's just important to know, because it changes the dynamics of the healthcare world. And then we'll talk about Kenneth Arrow. So he wrote a paper in 1963 called The Uncertainty and the Welfare Economics of Medical Care. And in that paper right here, it's beautifully written. I have the link below if you'd like to take a read. But in there, he lays out the fact that a consumer doesn't know when they get sick, and that uncertainty leads them to demand healthcare because they want predictability. And when they demand healthcare, they're going to pay a higher price for it than they should. And so he goes through this paper outlining the case for health economics and why a regular economy is very different than a normal economy. And it's one of the things I just mentioned throughout the chapter. Okay, let's move to chapter 2. Chapter one was really just a high level view of a health economy, and the reasons why we look at health economics. Chapter two, we're going to get into some of the microeconomic tools. So first, let's think about what is microeconomics. It's the behavior of individual decision makers within the health economy. So how do we make decisions? It looks at individual decisions that are made based on a variety of factors, which could be price, it could be scarcity, while macroeconomics looks at the people as a whole. So macroeconomics would take all people's individual decisions and roll them up. Microeconomics is how would John Doe make a decision in the healthcare economy? And what we want you to learn is microeconomic tools that can be used to evaluate a market and the potential behaviors of individuals in that market. Okay, so first tool is a production possibility frontier tool. And all it is a chart and graph that helps to highlight trade-offs that occur. So remember we talked about opportunity costs? So this is a tool to sort of discuss opportunity costs and look at the marginal unit. By marginal unit, what I mean is what would I do with one extra dollar on the margins? And when you look at the chart, which I'll show you in a little bit, if you're within the chart, you're inefficient because you're not maximizing your efficiency throughout the productivity. And if you're outside the chart, that's actually something that's unattainable because there's just not enough resources. And so what this chart is used to do is to depict how to have trade-offs between two different decisions that don't leave anything on the table and there's no waste. You want to maximize the decision. So what the heck am I talking about? I'll show you. Say Malloy College wants to build a football stadium and they have to choose between how many classrooms they could have versus how many seats would be in the football stadium. Because if they build the football stadium, it will limit the amount of space they have for classrooms. So they have to think about the revenue that they'll make from football games versus the revenue they'll make from having classrooms, right? So here at point A on the frontier curve, I can have a 30,000 seat stadium, and if I build that, there will be no other room for classroom seats. So there's no opportunity cost because I'm not giving anything up, right? But then when I have a 28,000 football stadium, I will still have room to build 200 seats for classrooms. And so what am I giving up? 2,000 stadium seats. You get that? Because I built 200 classroom seats. The space I needed for the 200 reduced the amount of stadium seats from 30,000 to 28,000. So I'm giving up 2,000 football stadium seats. So I would have to run an analysis to say how much ticket prices would that be to find out which decision I should do. And you can calculate the rest of it. I fill it out for you guys to find out all the offsets. So I can go as small as a 12,000 person stadium seating arena and have 1,000 classroom seats, but I'd be giving up 5,500 from point E. I'd be giving 5,500 more seats opportunity costs. So when we put on the graph, this is how we would lay it out. I have stadium seats, classroom seats. I'd plot the points, 30,000 and 0, 28,000 and 200, and I'd draw the line. And so on the previous slide, if I'm below the line, that means I'm not maximizing my space. So that means I built a stadium, I built classroom seats, but there'd still be space available, which means it's wasteful because I could have built either more classroom seats or I could have built more stadium seats. So you never want to be below your frontier line. That's why it's important to show the line in the first place because you don't want to end up below it. That meant you gave up free space, and just having free space means you're not maximizing your dollars. And I can't be above the line. Say if I'm above the line, that means I have too many seats that is possible to build in the space that's available. So this would be the tool that you would use to say, here are my trade-offs. How many classroom seats do I have, and how much more tuition can I earn from students versus how many football seats do I have, and how much money can I earn from football tickets? There's no right answer. It's really just a tool for you to make trade-off decisions and to make sure you're maximizing your revenue. Okay, let's talk about demand curves and supply curves. So demand curves are all about consumer demand. Demand curves depict the behavior of consumers only as price changes. Price drives our demand. If something's expensive, we want less of it for the most part. If something's cheap, we want more of it for the most part. And so we try to measure those changes in demand. And this Latin word, again, like I said, in all of our models, we're going to assume all other things are held constant, which helps us isolate the impact just to price, right? And again, that goes to when we do our models, we're trying to make models in a perfect world. So if we know what happens in a perfect world, then we know what can happen and look at it in our real world. And like I said, generally people buy less at higher prices, causing a downward sloping line. So whenever you see demand curves, remember that the line will be downward sloping. And elasticity is the measure of responsiveness of demand of price. All that means is if the price jacks up, you want to measure how much less people demand. If people still buy it, even though the price goes way up, you're inelastic. But if people stop buying it completely when the price goes up, then you're elastic. Specific, here's an example. That umbrella, if it's $6, how much less would people buy it if it's $6, right? Versus if the umbrella was $100, how much less would people buy it? No one would buy a $100 umbrella, but people may still buy a $6 umbrella. So the elasticity for an umbrella is there. Now think of health insurance. If there is a drug that's going to cure cancer and you know this drug can help you and it's $5 million, people still would fight, especially because they have insurance, to get that drug and to use it despite the price. And so the price for the cancer drug is inelastic because despite the price, the cure outweighs the price. The value of the cure outweighs the price, so people will still buy it. Versus the umbrellas, people will be like, I'm okay, I'll get wet. That's an elastic price is umbrella, inelastic price is the cancer drug. So let's depict the demand curve. This is how you're going to show it on a chart. Price is on the left side. You can see price goes from $0 to $5, and then quantity is on the bottom. So coffee goes from 0 cups to 5,000 cups, right? And then the downward sloping line that you see is the demand curve. And so here, Starbucks is selling 2,100 cups of coffee during the morning at $3.25 a cup. So the demand curve there is shown on the line. And then if I raise the price up, you would go to the demand curve to see where it falls. McDonald's sells their coffee at $2.25. So you can see there's higher demand at a lower price. At $2.25 a cup, 3,000 cups of coffee at McDonald's are being sold, which shows as the price goes lower, people demand more, right? And so this is pretty much how you read a typical demand curve. So you can see how much people are willing to buy at what price. And then because I can see how much cups McDonald's sold versus how much cups Starbucks sold, and I know the price difference is $1, I know $1 can change quantity by 900 cups. So now I'm measuring elasticity. Now, what happens when people make more money? So I'm shifting the demand curve. When I shift the demand curve to the right, that means people have more money. Shifting demand, I'm causing demand to increase. So everyone gets a raise, and with a higher income level, their demand for coffee changes. So think of Starbucks. When people had a raise, look at what happens. The $3.25, the people still pay that price, but it goes out to 2,700 cups. So more people are willing to buy Starbucks when they have a higher income, because now $3.25 doesn't look as bad. But the same thing happens to McDonald's. More people are willing to buy McDonald's cups. So McDonald's also grows to 4,100. And so all this depicts is as people's income increases, they will demand more. Some people left McDonald's and went to Starbucks. Some people weren't buying any coffee, but when they had a raise, they decided to buy coffee and started going to Starbucks. And then some people who thought they didn't want McDonald's, but Starbucks was too expensive, when they got a raise, they started buying Starbucks. So all in all, demand increases when income goes up. So let's talk about how do we shift demand. I showed you one way to shift demand is income. There's other ways to shift demand. So income, quantity of goods people want to buy generally increases when their price goes up. And it's just interesting to think about if yourself, if you get a raise, right? Do your expenses grow? You would think like as you get a raise, you would have more money. But usually what happens when you get a raise, you increase your expenses as well. So your take-home pay sometimes stays the same, even though you have more money, because you start to, buy a fancier car, you start to buy the more expensive stuff at the grocery store. You buy a new apartment that's more expensive. Your expenses go up with your income increase. And then there's normal goods and inferior goods. So normal goods are, as income goes up, demand goes up. So a normal good would be like a nice handbag, right? As I get more money, I will buy the better handbag. An inferior good is as income goes up, demand goes down. So that's like the handbags that are fake, that are sold, on the street. Those are inferior goods. So I'll leave those fake bags alone because now I have enough money to buy the expensive Chanel bag, for example. And so inferior goods are the ones like the no frills that you see in the grocery stores. Instead of Frosted Flakes, it's the ShopRite brand. Those are inferior goods. You leave the ShopRite brand and you start to move to the normal goods, the regular Frosted Flakes, as your income goes up. Another demand shifter is taste. Quantity of good can increase based on the preferences of the consumer. So just taste. If someone likes something more than another, then their demand for it will grow versus if someone dislikes something. And so taste can definitely shift the demand curves up or down too. And then other prices. So this is key. There are substitutes and complements. Substitutes are goods purchased instead of a particular good. As substitute price increase, demand for the current good increase. So what does this mean? A substitute for coffee could be tea. If coffee is way too expensive, people would substitute a caffeinated hot beverage with tea, right? So here we're saying if coffee increases, the demand for the current one increases. So if coffee gets too expensive, then the demand for substitute increases. More people will get tea if coffee prices increase. Complements are different. Complements are goods purchased with a particular good. As complement prices increases, demand for the current good decreases. So an example of this, typically you'll see this with like sandwiches and tomatoes, right? Sometimes I remember a couple of years ago, the tomato prices went up, so sandwich price went up. And so the typical sandwich went from $5 to $8, and the demand for the sandwich went down, but the reason why the sandwich was going up wasn't because the meat was more money or the bread was more money, it was because tomato was scarce, and so the price of tomatoes went up, for example. So complement goods can increase the price of your current good because they go together, for example. And then insurance, we talked about this. Insurance reduces the price to the consumer at point of sale, which increases demand for healthcare services. So what's an example of that? We talked about the cancer drug. If I didn't have insurance, it's a $5 million drug. With insurance, it's a $10 copay, right? So by buying insurance, and I reduced the price to the consumer, so I increased the demand for the $5 million drug. So more people would buy the drug with insurance than without it. And that's why when we give the uninsured population insurance, demand increases because with insurance, they demand more services. On the flip side, we have a supply curve. And supply curve depicts the behavior of suppliers only as price changes. And in the health economy, suppliers are doctors, hospitals, health clinics, pharmaceutical companies, home health agencies, nursing homes, anyone who's supplying health. Generally, suppliers will offer more goods at a higher price, causing an upward sloping line. So this is what's interesting. A doctor, whether he wants to believe it or not, from a health economics perspective purely, will want to see more patients if they're getting paid more money. And so as a doctor, they contract with different health insurance companies, Empire, Blue Cross Blue Shield, Health First, United Health, and potentially what this is saying is, if I get higher reimbursement from Empire, Blue Cross Blue Shield, I want to see more of those patients more often because I get paid more money than I do from, say, a Health First, where I get maybe paid less. And so I'll supply more healthcare services to people where I get paid more money. Elasticity is a measure of responsiveness to supply. So how much do I decrease the supply of healthcare services based on the amount of money I'm being paid? If my office visit is $100 and Empire pays me $120 and Health First pays me $80, what's the difference in how much healthcare I want to provide to the Health First patients versus the Empire patients? And I use those two because I worked at both places. And that's just an example. And the suppliers are more likely to invest more time and money to goods that reap the most optimal position on the supply curve. And that gets to what we're saying. I will try to book more appointments for the Empire patients, potentially, if I'm getting paid more money from them versus the other patients. And that's purely looking at it from a health economic perspective. So this is what a supply curve would look like. You can see it from $0 to $100. You can see quantity from 0 to 2,000. This an example is Columbia Coffee. So they are offering 8,500 bushels of beans. I don't even know if beans come in bushels at a price of $48.25. That's what the supplier is selling. Columbia Coffee is willing to sell 8,500 bushels of beans for $48.25. Starbucks is willing to pay $55 a bushel. McDonald's is not. So you see the suppliers offering a higher price to Starbucks, and they're getting a higher quantity. So it jumps up from $55, the quantity jumps up to 11,000 bushels, right? Now, Brazil Coffee enters the market with competitive pricing to remain competitive. Columbia Coffee Co. had to change their prices. So here you can see the supply chain move out. So here you can see the supply curve move out. That means supply grows, right? And because a new competitor came into the market, when supply grew, the Columbia Coffee Co. had to lower their price based on the more suppliers that entered the market. So one thing to note is when you see more supply come into a market, and examples like urgent care, pop up, it tends to drive down prices because there's more competition. There's more people supplying the healthcare. And if there's more, it meets demand. Demand comes down. So how do you shift supply? Technology can shift supply. Supply increases as technology makes it cheaper to produce goods. In a typical economy, that's true. However, there's examples where technology actually increases the price. An example is when you have a new oncology machine, a new radiology machine, a new machine that doctors use. When they buy this new expensive machine, they try to use it to make their money back. And so by using it, they're actually inducing demand, which we're going to talk about. You induce demand by making sure you use the machine as much as possible on as many patients. And because you have asymmetric information, you're going to tell the patient that they need this service, and usually they'll say yes. So in healthcare, technology a lot of times doesn't decrease the price of services. It actually increases it because of asymmetric information. Input pricing. As the cost to produce a good, like labor, increases, the cost of good increases. So as nurses' salary wages grow, as doctors' wages grow, as the leasing to lease a building or to buy a building, as real estate prices grow, all those are input prices into the delivery of healthcare. If they grow, healthcare costs also grow. Prices of production-related goods. Generally, the rise in related goods will negatively correlate to the production of a specific good. This just speaks to if you're a dentist, all of the supplies you need to be a dentist, if they increase, then you're going to charge more money for your visit. The size of the industry, we just looked at that in the previous example. As new entrants appear, competitiveness increases, which increases supply. So when you increase supply, you lower price. That's exactly the example I showed on a previous slide, where a new coffee competitor came in and that decreased the price overall for the supply of beans. And then acts of God. So weather can impact supply, demanding on goods being sold. So an example of act of God is when we talk about the swine flu epidemic or Zika. These are acts of God that occur that increase demand drastically because people get sick and then they have to go to the doctor. So you increase demand, which can increase price. So what is equilibrium? You take the supply curve, you take the demand curve, you put them on top of each other, and where demand and supply curve intersect within a competitive market is your equilibrium. And what that means is you just found a place in the market where a consumer is willing to spend money and give it to a supplier, and at that price, the supplier is willing to give healthcare costs. And so everyone's happy. Equilibrium is where consumer gets what they want, the supplier gets what they want, the market is efficient. You found a perfect price point. In real life, rarely happens. And if it does happen, it's constantly changing because there's new entrants and things change. But in a perfect world, supply meets demand, right? At higher prices, there will be excess supply, an inability to sell all their goods. At lower prices, there'll be an excess in demand. People will be willing to pay more for the good. And as demand and supply curves move, equilibrium changes as well. And so the question I have below is, how does a breakthrough in LASIK surgery impact the market for eyeglasses and contact lenses? So LASIK surgery used to be very expensive, right? Now it's the same day, it's roughly $2,000, it's very cheap. And so LASIK impacted that surgery by decreasing the price and it becoming the demand for it growing because the price went lower. It now impacted the eyeglasses and contact lens market because once I get LASIK surgery, I use those things less. And so this is an example of technology lowering the price of something, as an example. So I want to touch on a couple things, which we'll get to later on in other chapters, but I just want to touch on it. So I'm not going to go through everything on these slides, but I do want to talk about utility. So consumer theory is how rational individuals make consumption choices when faced with limited resources. We talked about this, right? When you have budget constraints, what do you do? So the way we do that is utility, and that measures one level of satisfaction within various combinations of consumer goods. We will do a whole section on utility, so I'm just gonna briefly touch on it. But there's cardinal utility, measurable utility, and there's ordinal utility, measured through ranking. Ordinal is, I like it first, second, third. And cardinal is, along a spectrum. And marginal utility is trying to say the extra bit of usage. Utility is like usage. How much do I get out of this good or service? The extra bit of utility achieved by consuming one more unit of good, right? So you can see this little slope. And the slope, as wealth grows, utility grows, and you can see it start to flatten. What utility is trying to measure is what $1 more means to somebody. And the wealthier they get, $1 means less. But when someone's poor, $1 means more. And I just say that now, we will get into it in more detail later, but I did want to touch on it in the beginning. I'm not going to touch indifference curves, but I did want to get to consumer equilibrium. In light of budget constraints, consumers seek highest attainable indifference curve. So the equilibrium point is where the slope of the indifference curve equals the rate the individual can trade both goods. And all this means is for a consumer, they are seeking equilibrium as well along the demand curve. And the way we look at demand curves is you can have 5 people. So say this whole class, we had demand curves for every person in the class. We would roll that together into this third one where you see quantity is 9, into one big demand curve to see the difference. So everyone can have a different demand curve, but then when I look at the market, I can measure the market's demand curve as a culmination of all the different separate individual demand curves that someone will have. And then the last piece I want to leave on is elasticity. So remember we talked about how to measure the response of price and how it changes demand, right? The responsiveness of quantity consumed due to changes in other variables in light of budget constraints. Consumers seek the highest attainable indifference curve. So we define it as the change in the dependent variable. This is all a lot of mumbo jumbo jargon language that you'll see in your textbook. But literally what we're trying to find out is the change in price over the change in demand. And so the change in quantity over the change in price will depict elasticity. I'm trying to measure how much will a change in price change how much I demand of something, and I can measure it. And if something is close to 1 versus 0, will tell you if it's elastic, super elastic versus inelastic. If it's 0, it means it doesn't matter how expensive it is. If I need it, I'm going to buy it. That's inelastic, and you'll see that when you do this calculation. Versus something that is very elastic. $1 means I won't buy it. Oh, it's too expensive. That's like going to the dollar store and seeing something that costs $2. You're not going to buy it. That's very elastic to price. So this calculation is very important because we always want to know how elastic is the good and how elastic is the service. Usually in healthcare is inelastic. Not cosmetic surgery where you can decide to have it or not have it, but if you're sick and there's medicine, you're usually going to pay for it. And you see this in sort of the increases of some of the drugs, like the EpiPen, the cost increase went up. The reason they could increase the rate is because regardless of the price, people are going to buy it. On top of it, insurance lowers the price for the consumer, so they're going to demand it more than they already would, even though the price goes up. So this elasticity portion is a very important part of the course. And so, we can talk about goods or services that are inelastic, which I mentioned some, versus goods and services that are very elastic. And then lastly, a monopoly. You rarely see this in real life, but Amtrak is a monopoly. The LIRR is a monopoly. What it basically means, there's no price control, or sole price control is within that entity. The monopoly runs the show. LIRR can charge whatever it wants because no one else is there to compete with it. And so it's very hard to get to market equilibrium with a monopoly. And so what we try to do is increase competitors into the market. So with that, I will end, and I'll throw up a question on the discussion board from early on about the increase in doctors and nurses from 2000 to 2009 and ask why. And if you have any questions, feel free to email me. And thanks for listening to Chapter 1 and Chapter 2.